welcome to today's webinar, Modernizing Demand Generation for HIV Prevention. We're just going to give it a minute just to get everybody on board. So welcome to this afternoon, this morning's session from wherever you're joining us from. My name is Lucy Maikweki, and I'm the New Product Innovation Technical Lead at the South to South Learning. And we are co-hosting this session with the Global Fund. So welcome so much, everyone. Just as we progress, kindly introduce yourselves on the chat. Just write your name and where you're joining us from. And as we continue, we are going to be having also translations. So just click on the show captions so that you can get your translations. And as we move along, if you have any questions, kindly click the Q&A and put your question there. We are going to be addressing the questions as we go along. So welcome so much. Introduce yourselves on the chat. Let's move to the next slide. So for today's session, Modernizing Demand Generation for HIV Prevention, as mentioned, I'm your chair for this session. We will be joined by the Global Fund, as well as Global Fund sub-recipients and principal recipients. Our first session will be led by Susie McLean, the HIV Senior Advisor for HIV Prevention within the Global Fund, and she will be taking us through the GC7 Global Fund investments in HIV prevention, information, communication, and demand creation. And her session will segue into Hamsafar Trust, a Global Fund sub-recipient in India, that will be taking us through digital demand generation within NetReach, an organization or a project in India. We will have Tatiana Deshko from Alliance for Public Health from Ukraine, who will also be taking us through digital solutions in increasing health access within Ukraine, as well as the Eastern Europe and Central Asia. We have Jen Hecht and Tegan, who from the Building Healthy online communities, who will also be taking us through demand generation for HIV self-testing. After that, we will have our question and answer sessions. So please put your questions, write your questions on the Q&A or put them somewhere, and we will have a session where we will have an opportunity for the presenters to respond to your questions. So over to the next slide. So for this webinar, we will be exploring data-driven or data-informed strategies to generate demand, to generate demand at scale, looking at leveraging innovative digital channels for virtual platforms, for example, dating apps in resource-constrained settings. We all know that demand generation plays a very key role in creating demand for HIV prevention, creating awareness and access to products and services, and with the increase in HIV prevention options, but also the reduction in funding for HIV prevention, then it becomes very critical that we use whatever resources we have to create demand in a very smart manner in order to sustain awareness and also continue to increase access to the new prevention options that are coming. So the objectives for this session will be to highlight the importance of demand creation in that context. We want to also be able to demonstrate innovative data-driven strategies for creating demand in resource-constrained settings, how you can use virtual or online approaches. We will be showcasing country-level examples of effective demand generation within Global Fund supported programs, as well as explore opportunities for collaboration with private sector and digital platforms. We will be able to also showcase or link demand generation or efforts to the GC7 and reprioritizing and preparing for the GC8, especially with the scale up of LEN prep, and identify practical tools and approaches that can be adapted or scaled across different contexts. So those are our objectives for today's webinar. And I want to take this opportunity to welcome Susie McLean from the Global Fund, the HIV Prevention Advisor, to just take us through the GC7 Global Fund HIV Prevention strategies or funding for communications, information, and demand generation. Welcome, Susie.
Thank you, Lucy. Hello, colleagues. And thanks to South Learning Network for hosting this session. We're enthusiastic about this topic. We're great to be work closely with the South Learning Network that can help us to have a discussion or a debate around these issues. I also want to acknowledge my colleague Carla Rodriguez, who joined the call, and Carla and I work very closely on these issues together. I just wanted to note that there's a bunch of us at the Global Fund who are interested in these issues, and Carla, who you can see there, is prominent in that work. I also wanted to wave to and say hello to our colleagues from Amsafar Trust and Alliance for Public Health in Ukraine, two of our Global Fund partners who are doing really interesting work in this area. And we thought it would be good to for people to see that work. It's by no means the only, not the only interesting work in the demand creation for prevention space. There's a lot of interesting organizations and a lot of interesting developments, but these were two examples that we really wanted to shine the light on. And so a special hello to colleagues from Amsafar Trust and Alliance for Public Health. And so, yeah, just to say, these are a few thoughts really, rather than kind of, I'm not going to set out a particular, set of new rules or anything. I'm really just kind of wanting to reflect some of the thinking that we're doing and some of the observations that we're making when we look at our investments in this area, and deliberately trying to kind of prompt more of a discussion or a debate around how we modernize and adapt HIV prevention, communication, demand creation in general, but also in particular as we see things like the increasing availability of new prevention options, such as long-acting PrEP, and some of the other new products that are in the pipeline, but also really importantly, we rethink demand creation for example, condom programs, or for needle and syringe programs, all the different types of programs that we all work on together to get more prevention options into people's hands. But one of the things that I think we all share is an interest in, how do people who need prevention know about and believe in these prevention options? How do they make good choices? So yeah, we've been funding a lot in this area for a long time. So this is just an opportunity to kind of reflect together on what we've invested on in the past, what some of you people have delivered in the past, and where we might be going in the future. Next slide, please. I've just got a few slides just to really open up the discussion. First thing I wanted to say, this is a real Global Fund perspective, and I accept that there are many wider donor perspectives, but just kind of wanted to situate this discussion in terms of the Global Fund's investments. So in the current grant cycle 7, we estimate that we're investing about 1 billion in HIV prevention. It's by far the largest investment that the Global Fund's ever made. It's a really important priority area for the Global Fund. And it's been something, there's something like a 50% increase in since the last couple of cycles. And inside that 1 billion investment, we have these big categories that I'm sure many of you are familiar with. For example, the condom category, the PrEP category. One of the biggest categories is this one that's relevant to this discussion, and it's titled HIV Prevention, Communication, Information, Demand Creation. And some of you might be familiar, it used to be called BCC, Behaviour Change Communication category. We renamed it to really emphasise demand creation for HIV prevention options. And it's been the case, I think, it's been named this way in GC6 and GC7. And so we estimate, final numbers are not in, but we estimate that something like a $200 million investment in Grant Cycle 7, so loads of money. And one of the big questions that we have, so we really welcome this direction. We welcome the kind of the prioritizing of this work by Global Fund recipient countries. But one of the big questions, I think, for all of us, and certainly for those of us in the HIV team at the Global Fund, is trying to understand the impact of this investment. So there are big questions for HIV prevention overall in terms of kind of measuring impact. We're doing quite a lot of work in that area about outcome monitoring. But for this particular bucket, the communication demand creation work, it's particularly challenging, I would say. We don't have a lot of data in the area of understanding impact in this area. And yeah, to be frank, seeing a way forward in this area, demonstrating the kind of value, demonstrating the impact is not easy to do. So rather than kind of saying we're going to introduce a whole new set of indicators, whatever, we're not. Discussions, have high quality dialogue with implementers and other stakeholders to ensure that we're all kind of working together to really maximize the impact of this investment area. Next slide, please. So this is really a slide that reflects a lot of the things that we're thinking, and we just wanted to share that with you. We're doing some of this thinking with some of you who are on this call, and yeah, we really kind of think the idea of a community of practice in this area is a kind of the type of aspiration that we have, so that we're all learning from each other. But these are, I think, some of the imperatives or some of the priorities for the Global Fund in this space. And the first one is around the imperative to expand the reach of HIV prevention demand creation for lower costs. So those of us have been around a long time in the HIV prevention space, and you know, those of us that have got this historic perspective can see that one of the ways that we've been doing demand creation or communication for prevention has been very much a person-to-person approach, like a peer outreach worker reaching, you know, 60 people per month or whatever the ratio is, to give them information about HIV prevention, HIV transmission, condoms or whatever. And we think that that's still a really important platform and an important approach to information education about prevention. But we also know that in addition to that, online strategies are both increasing the way that people understand health information, but also enable us to reach many, many more people at a much reduced cost. And we've got a few examples of that coming up, but I just kind of want to emphasize both. We're not suggesting that online approaches to prevention demand creation is a replacement for the kind of peer outreach approach, but we think that the two of them should be increasingly blended and delivered in a side-by-side way. We also know that, yeah, digital campaigns can be highly cost effective, and as a prevention financing organisation, that's terribly important to us. One of the things that's really top of mind when we think about this type of evolution towards digital or online campaigning for prevention is this issue about expertise. Number one, first thing I want to say about expertise is the types of organisations that we know are doing HIV prevention communication at the moment. For example, organisations that are very embedded in their communities and have a lot of expertise about the interests and the values and the needs of their communities. We recognise that as really critical expertise that we want to protect and expand. But we also know that sometimes those organisations, those community-based organisations or those community-led organisations may not be experts in communication experts. And we know that there's a lot, in general, I would say, there's a lot of expertise in the health communication sector that sometimes we're not bringing to HIV prevention. So one of the things that we're really interested in is partnerships between private sector communication specialists, and kind of on the ground community organisations to bring those two different types of expertise together towards kind of really modern and far-reaching health communication campaigns. One of the things when we look at when we analyse the budgets in this area is that we don't see a lot of budget for campaign delivery. We recognise that we're part of that problem. The kind of budgetary categories that we have are a little bit dated, I would say, a bit old-fashioned. And so we've tried to change those to really emphasise this idea about partnerships between private sector communication specialists and say CBOs or SRs or SSRs. And so, yeah, we're really wanting to see, and we're trying to set things up from our side to support better investment in these partnerships for campaigns that are led by both private sector experts and community experts. One of the things that we're struggling with generally, I think it's a struggle for all HIV prevention providers, are these issues around monitoring. You know, the era of kind of tracking the reach of HIV prevention by individual peer outreach worker is what we have now, and it's still really important. It's kind of one of the main ways that we have that we can know about the reach of HIV prevention into the communities that really matter. But we also know that there's huge opportunities there that certainly from the Global Fund perspective, we're not tapping sufficiently in order to really understand in real time the reach of HIV prevention communication, so that we know that digital methods offer a lot of opportunities there to kind of track where messages are going, to track the way people engage with HIV health communication, and that we need to bring that more into our monitoring efforts. And then the other big opportunity, I think, from kind of digital platforms or mHealth related approaches to HIV prevention communication is the ability for some privacy and some security, as long as the right kind of systems are in place to protect confidentiality and privacy. We are getting lots of indications from lots of places that a lot of people prefer a kind of a way to communicate with people that is not necessarily face-to-face, just as an opportunity to talk about, you know, sexual practices or drug using practices that might be controversial or stigmatizing. So there is some real opportunity there about kind of privacy, I think, in terms of the way people talk about their sexual practice or their sexual risks or drug using risks, that where there's some unique opportunities with digital or mobile phone based communication. And yeah, I just kind of want to emphasize that we recognize that digital approaches are not accessible to everyone. This is why we're not saying this is the only thing that matters. That the standard way of reaching people through kind of face-to-face peer-based approaches, we still really value highly. We're still supporting. We're just kind of wanting to really welcome programmers that are adding on these digital or mobile phone-based methods of reaching people with health communication. So they're the types of ways that we're thinking about this work. I just wanted to share that with you. A lot of the things that people on this call are doing are influencing us, and yeah, I suppose we want to send out some signals that of the Global Fund's interest in this area. And then I've just got one more slide, and then I can hand back to you, Lucy, and we can wrap up. So it's really just a really kind of quite a...
If you're able to wrap it up in maybe under a minute.
Okay, these are just a slide that we'll show this slide that contains some really specific information about our budgetary categories. So as I mentioned earlier, the budget categories are a bit dated. Carla's been doing some great work to update those budget categories. So I think, in short, as I hand back to you, Lucy, I suppose the message well, two messages here. One is to say that when applicants come to the application materials for GC8, we're hoping that you will see there's kind of more space and more flexibility in the way that we've set up descriptions and budget lines and stuff to develop this type of work in a more holistic way. My final point as a handbag is to say we're also working with the Global Prevention Coalition on guidance in this area. And I think that's an really important point for us all to know that there's new guidance coming in this area that kind of reflects a lot of these concerns that we're discussing today. With that, Lucy, I hand back to you and look forward to the discussion.
Thank you. Thank you so much, Susie, and apologies about the time. We are going to move on to now our presenters. We have Achana Shetty, who's the communications manager for the Hamsa Trust, and she leads the communication for NetReach, which is a global funded virtual outreach program that connects India's online populations to HIV prevention, testing, and care. Welcome, Achana.
Thank you. Thank you, Lucy. I hope I'm audible.
Thank you.
Yeah. Hello, everyone. I lead communications for India's largest online HIV intervention project called Project NetReach. In this talk, I'll be taking you through all that we think we've been doing and has reaped great results for us, especially for a population the size of India. So how do we run demand creation is what we'll be speaking about. Thank you. Next slide, please. What we set out to do is to change the vocabulary around how we speak about HIV, which is ridden with a lot of stigma and a lot of fear attached to it. And when we started building NetReach, we definitely, from our own ground level experiences, wanted to change the way we speak, the way we counsel, and the way we also create a program that's acceptable to the masses, and especially people who are online. We have a sizable population online. Next slide, please. Who we are is we are the Humsafar Trust, and we are the oldest LGBTQ community-based organization in India. We've been doing this for the last 30 years. We've been running online on-ground HIV intervention projects, and in a small way started going online a few years ago, and currently are running the biggest program online. Next slide, please. It's well, thank you so much to the Global Fund for helping us take on this project, because their support has helped us work with innovation and to reach the hard-to-reach populations all across the country. As you see in the next slides, you'll be able to see the volume of people that we've been able to reach, and that's only because of the support we've received and the understanding that we've received from the Global Fund. Next slide. A little bit about our project people. We are a lean team. We currently have 12 virtual counselors who are in different parts of the country and who meet clients online through the efforts of communications, advertisement, and their own outreach. We consist of a communications team that's creating demand generation, running ads, and also we have a website through which we run most of our booking process that links people to the on-ground services. India has a very robust network of government systems and also private players who help out with HIV testing and treatment. And that's the whole idea behind this project, is to connect people to the ground level eventually. Next slide, please. I just wanted to, before we get into the main slides, I wanted to show you what the power of communications can do to reach the client online, create a referral, and then link them to the on-ground services. If you look at the left side, it's an advert that we created on Meta. And this is an advertisement for one of our counselors. He's presently in the south of India, speaks a particular language. Once you click on this ad, which is on Facebook, you are connected with our counselor directly through WhatsApp, which is a very popular app in India. And that's where the conversation begins with the client, where we understand their sexual health history. We convince them for taking up tests, and we also help them with any myths and address any fears that they have. Moving from there, we take them to our website, which is netreach.co.in, which has a list of all the healthcare services providers mapped out there. And the client is free to choose any of the closest centers that they want to go to or any other. Once they book an appointment, a referral slip is generated. And if you look at the extreme right, that is the proof that they have been connected to the on-ground services. Next slide, please. I wanted to show you this before we show you the actual work. The volume that digital demand generation can accomplish is absolutely amazing. I mean, it is cheap. It is definitely cheap to run digital campaigns versus traditional ones. And for the size of India, we've just scratched the surface, but this is the volume that we can achieve if we run continuous ads. Next slide, please. I also wanted to talk about the client. We are a 4-year-old project. We've been pretty much trying to understand the online populations over time. When we started running ads initially, people did not have a vocabulary for sexual health, is what we understood. When we ran an ad, say HIV testing, or if we started running reels about sexual health, people took it the wrong way. They thought we're here to have sex. They thought sexual health pertained to erectile dysfunction. And even if they had a problem, they could barely say, so type to us something like, our DMs would be flooded with, I have a problem. And then people would go silent. Over the years of creating the kind of ads that we've done, the creation process itself involved understanding these gaps and creating materials that would resonate with and also build trust amongst people and ask them or even educate them or raise awareness about their own sexual health and what are the right questions to ask. And if you see on the right-hand side, now people ask us direct questions related to HIV testing, related to PrEP, related to any issue that they face. If they've had unprotected sex, they are very open to speak with our counselors and also connect with our services. Next slide, please. This is a snapshot of the proof of what people are finally connecting with us. From the silence of high and erectile dysfunction, people are trusting us a lot more. And NetReach has been able to create that kind of safe space where you can stay anonymous. We are not here to really tell you not to have sex. We are not here to give you any kind of advice except for sexual health protection and prevention. And the next slide also is a similar snapshot of what people are confiding in us, talking to us about any encounter that they have. Maybe my condom broke and I'm afraid that I might have got an infection. And even if they need mental health support, our counselors are here to help them online. Next slide, please. So what does it take to create a campaign of this stature is one is we've understood and we've known this for a long time because we've been here for a long time that the ground realities are very different from what we actually have been communicating is what we understood. Building trust is such a big factor for us. People, especially since it's online, people tend to be wary and do not, might just may feel that they might be exposed or anything like that. So building trust through campaigns and continuous campaigns need to run for people to know that we exist here and we are absolutely serious. Using innovation, because the digital platforms itself are evolving every day. We are right now in the era where we're using AI effectively, and staying relevant is extremely important. Working with regional influence in terms of creating with language, creating with certain type of lingo, which people might be more easy to connect with us is also necessary. And investment, as we all know, digital campaigns run when there's money. And that's the only way forward. Next slide, please. little bit of how we created. If we saw that there was a gap in creation, we started talking a certain way, and this is where we started seeing the change. People started liking the kind of materials we started posting on our official platforms and through ads as well. We started talking about sexual health. We started talking about what's there on my body. Let's talk about my body. Let's talk about my preferences. If I'm using sex toys, which a lot of us do, but it's such a quiet communication out there. If I'm indulging in oral sex or anal sex, it's important to talk about these matters as well. And that's where people started appreciating the kind of content and also connecting with us thereafter. Next slide, please. We are omnipresent. That's where relevance comes in the picture. You need to be relevant. You need to be available all the time in the digital sphere. We started working with Meta. We're running ads on Meta, Instagram, Facebook, on Grindr as well, on Spotify. We started creating podcasts. We started creating radio ads. We started pushing advertising on the big screen theater as well. And we also ran ads on OTT platforms, for example, Hotstar being one of them. Next slide, please. So what have we learned after 4 years of running robust campaigns is their regional ads tend to do very well. India has several languages, and we currently work with about 12 to 16 of the most spoken languages, because regional ads tend to make people trust us more. English or Hindi, as such, which are the main languages, do not really work as effectively as regional ads do. And working with Google Trends, or working with data, or at least reviewing what your advertising has done, is especially important for you to move forward. And direct messaging ads on WhatsApp is a big win for us. WhatsApp is a very popular platform in India, and WhatsApp has also allowed us, Meta especially, has allowed us to run really good ads. So our counselors can directly engage with populations when the ads run. They get direct calls from the clients. Next one, please. Working with data is also important, because when we are online, there are some practices that we do. Google, especially, there's a open platform called Google Trend, which anyone can look at. It allows us to see these are the states out here in India and who's searching for what, because you need to be relevant in what you're creating continuously. If I'm searching for HIV testing within a span of 30 days, I need to create a HIV test ad in that area within that span of time. So working with real-time data is also essential. And this is not only Google Trends. Listening to your teams who are at the ground level, they are the best people to know what's happening. And listening to them and then figuring out is also important. Next one, please. Staying relevant, like I said, riding on trends is also important. So we've been all across, we've been working with podcasts, any trending material you need to be creating continuously. Next one, please. Developing your website is also important. It's not only about ads, but where do these ads lead to? And that is our website. And we've been working continuously with websites. And also, I would like to say out here, it's important to have funds for changing with changing times also. Our website currently, we've been developing the chatbot, and soon we'll be able to voice search for any demand that's there on the website. Next one, please.
Hi, my name is.
Sorry, yeah. Influencers play a big role in building trust for the program. Please, please do work with a lot of the trending influencers out there in your countries. They are the ones who bring in the change, raise awareness, and also help the program move forward. Next slide, please. A little bit about the slide. If you look at the dollar sign, I mean, the USD gives you an idea of what investments and what kind of results we get eventually. This is just an ROI of the ads that we have been running. Next slide will give you a better idea about it. For example, if I run 28 ads, this is in a span of 2 months, about 4 months, I've been able to reach a larger population. That's why I said continuous funding for ads is essential for you to stay relevant. Moving on, please. Next slide. Collaboration is very important. Grindr especially has helped us run no-cost ads, which has made a big difference. Next slide, please. PrEP is a surprise one because this is just an insight. PrEP ads tend to do well, better than the HIV ads, because people are more aware. But of course, we also, maybe it's because of all the change that we've been able to bring through awareness, we do see a rise and uptake of these ads. Next one, please. To conclude, I would just like to bring in the challenges, though I might show you robust numbers out here, but the biggest challenge is we get flagged by platforms itself. We are banned on Google because according to the Google policy, it's sexually explicit materials out there. And speaking about condoms itself, it's something that they flag because it comes under their policy of contraception that they do not promote. We have to continuously change our ads. The creations that we do have to change continuously because anything that gets flagged by any of the platforms makes it harder to reach the populations. Next one, please. Key learning, and this is what I leave you with, change is the only constant, and we all know that now. And collaborating is a must. We've been very fortunate that we've been able to collaborate with our state agencies, which also built a lot of trust for us. And constant change and constantly monitoring and staying relevant is very important. Thank you so much. That's all from my side. And a big thank you to SSLN and Global Fund for giving us the opportunity.
Thank you. Thank you so much, Achana, for that very insightful presentation. Thanks. And next we are going to move to Tatiana Deshko from the Alliance for Public Health, who's going to be taking us through digital solutions in increasing health access in Ukraine, Eastern Europe, and Central Asia. Welcome, Tatiana. I want to encourage everyone to kindly post their questions on the Q&A. And Tatiana, you have 20 minutes. Welcome.
Thank you very much. My name is Tatiana Deshko. I represent Alliance for Public Health based in Ukraine. We've been acting in the function of Global Fund principal recipient for national grants, of regional grants for nearly 20 years now, and it's been a true privilege to be exchanging with many countries on African continent, learning from yourselves and now also sharing with you. So thank you very much for this incredible opportunity. I will focus on one of the solutions that we have developed. It's called Twin Digital Assistant, but maybe there will be some more in the presentation, and if I have a couple of minutes, I will say just a few words of them, but you're really welcome to ask questions about those and also keep in touch after the presentation. So Twin Digital Assistant, it's automating responses to similar questions from the known databases is nothing new, and there are mainly two ways of doing that. One would be using a digital human, someone who is very much like what I am now, a talking head on your screen on a computer or on a mobile telephone, or using a chat like a chat GPT or an online consultant. We have compared those and have really preferred to proceed with digital human because it seems stronger on emotional connection with a person, on a duration of this connection, on building trust, on ability to culturally adapt, and actually the outcome that we are seeking to achieve related to changing the behavior of a person in relation to HIV in the first place and to other diseases. So there is a number of scientific literature related to that. You are welcome also to look at it based on the references we have provided. Next slide, please. There are a number of so-called avatars digital humans, talking heads, there were several names really meaning the same, which have been developed and which function in the area of health. Sensely digital head, which is especially good on integrating with electronic health databases. Soul Machines has got one which has very good emotional expressions, something that catches you on the screen. Synthesia, DID, Replica. So they all have their stronger sides, and you can actually choose some of them to build your further campaigning on. Next slide, please. We have compared those as per the criteria of interactivity, of visual realism, of how easy it is to customize it, because we were planning to use it in a number of areas, in a number of countries. Thus, language support was very important, and emotion expression, indeed, how much we are able to actually drive the change, drive the difference in behaviors of our key populations. And you can see that actually the platform that we have chosen, it's with a Spain-based company that specializes in digital human. It's called UNIT. So we have chosen to proceed with them. So we use that technology of having digital human, but we have populated it with the necessary algorithm and data and approach to be used in our area. Next slide, please. Our digital human or virtual social worker, digital assistant, we call it him, her, them twin. It's an IT solution. It's based on artificial intelligence because it helps us to identify the question, what the question is, and to provide the necessary response to it. We have populated it with the initial database, which we would like to control quality of data on. It's related to HIV, sexual health, dependencies, mental health, TB, and we actually keep on adding these modules. We have developed it to reduce the burden on social workers, because sometimes they do not have enough time to provide the great volume of information for the key populations they serve, but also sometimes they would not know all of the latest updates on this information, taken how rapidly it is developing or how many contacts need to be kept in your head. So it felt really beneficial, and it can be accessible 24/7, especially in Ukraine. In the time of war, it was obvious that actually having lesser physical contact with social workers was beneficial. So it was really great to have someone who would be available wherever you are, whether it's an air raid siren, whether you're in an air bomb shelter or whatever. So it's really someone who can be there continuously to support you. So we have arrived at this solution. Next slide, please. We have our digital humans, they provide real-time conversation. So you ask now, you get the response now when you are online. So it does require to have the online, online connectivity. It works with 60+ languages, but it's still important to understand that with some languages, this solution works better, with some not so good. So you would still need to test it and to improve it. We have selected avatars, so we have developed several talking heads as real people have been recorded, and this we have started moving with several characters. Next slide, please. So here you see the real life recording in the green room. We have had one of the characters was initially provided by Unit Company. It's more of a generic character, but we also wanted to make sure that we could address a variety of populations. So we had someone who is an outreach worker for people who use drugs. And so we recorded him as a talking head. We also recorded a drag queen as someone who would serve more for a younger audience, for more of a party-like groups of clients. There is someone from LGBTQI community who is also a blogger himself, so it was also beneficial eventually, so attracting some groups of his contacts too. And we also recorded recently a military person from the battlefield to provide advice on safer use and safer sex for people in the military. So actually, we recorded a number of people who then became digital and became digital humans available all the time. Next slide, please. So we keep on experimenting a little. So we actually try more characters, try more ways of popularizing our digital humans, see what works best, which are the channels. So we are now in the mode when we have made some important decisions, and now we are trying to scale, but also try some new things out as well. We started in Ukraine, and most of our work has been in Ukraine for the last year, but we are also now working actively in Georgia, in Moldova, and we are recording a person in Kazakhstan very shortly. So it's actually a quickly developing tool, because with every because it's really easy to build on the existing kind of talking head. Developing new ones, it's so much cheaper. You just have to record new faces, update the database a little bit, and so it's becoming more and more cost effective. Next slide, please.
We have 5 minutes, Tatiana.
Sorry?
5 minutes.
5 minutes. Thank you very much. Sorry. Yeah, so it works that some of the information has been controlled for. So we have we have a database on some of the things that we want to control. But if a person is asking a question outside of this database, it can be something about even the weather or the mood or something else, then algorithm is that it would go to ChatGPT and the question would still be answered. So the person doesn't stay without an answer. Next slide, please. But you can configure it how you like it. So it's available on your on a PC or on a mobile phone, and yeah, we can see how it works. So let's go to the short video. Yeah.
Had sex at a party with multiple partners and I don't remember the details. Do I have any risks of HIV?
Yes, having sex with multiple partners can increase your risk of HIV, especially if there was no protection used. Since you don't remember the details, it's crucial to get tested for HIV as soon as possible. Additionally, consider speaking with a healthcare professional about post-exposure prophylaxis, PIP, which can help reduce the risk of infection if taken within 72 hours after potential exposure. Don't hesitate to prioritize your health and seek the necessary testing and support. For more information on HIV testing, visit www.phc.org.ua. If you have more questions, I'm here to help.
Which outreach worker is better, a digital one or a real one?
Both digital and real-life outreach workers have unique benefits. A digital outreach worker can provide quick access to information and support anytime and anywhere, allowing for anonymity and convenience. On the other hand, real-life outreach workers often offer personal interaction, which can foster trust and a deeper understanding of your situation. Ultimately, the best choice depends on your preferences and specific needs. Some people might feel more comfortable online, while others might appreciate face-to-face interactions. It's all about what works best for you. If you have further thoughts on this, I'd love to hear them.
It's been a difficult night for me in Kiev today. Can you tell a joke?
I'm sorry to hear that it's been a tough night for you. Humor can sometimes lighten the mood, so here's a little joke. Why did the computer go to therapy? Because it had too many bytes. I hope that brought a smile to your face. If you need to talk or need support, I'm here for you.
Yeah, thank you. Thank you very much. Really tried to show the variety of how it can work in different things which are more or less controlled. So, but having just a digital human there does not mean that you will reach your clients. So you really have to work hard on that. And it was, it was stressed in the previous presentations, very, very important. So we've been experimenting with that. We have done some work with social media. We have engaged some existing service providers, the NGOs who are physically talking to the service providers. We asked them, why don't you show them it on the mobile phone as well and try to do the virtual consultation as well. We have involved bloggers and other ways. So we really experimented. Please, next slide. And it's going, so kind of, we really focused on experimenting more. So now we are really building very much on those results. So like total meta reach has been 220,000 social media contact. Total visitors for the websites was 22,000 people. And we have about a little bit less than 6,000 conversations on the site, meaning there's really 6,000 people who have asked the questions, engaged. And from this conversation, we refer someone to request commodities or HIV tests, syringes, condoms on HIV tests. And we see that out of those who have had conversations, about 10% actually transfer to ordering commodities. So this would give you a little bit of a sense of this kind of reach with different things. We've tried, so indeed it's growing. The more you work, the more your coverage grows. We've compared it in a quarter with the reach of average NGO for physical work in Ukraine. So if an average NGO is reaching about 1,100 key populations in a quarter, in the same quarter, our virtual social work reached 1,500, so a little bit more than the average, but with time, the longer it functions, the more it reaches. So actually we see a lot of capacity in that. Next slide, please. So what people are asking, this is the main themes and questions are pre-exposure prophylaxis, HIV transmission, post-exposure prophylaxis. Most of it comes with the open questions, but we also have the prepared questions. If you just enter this chart, you can actually press on the prepared question, and they are kind of related to PrEP to HIV. So they also, they are guiding this conversation a bit. Next slide, please. So what we've seen is that the best promo efforts were working with social media and influencers. Really, when we have a community blogger who is engaged, and direct outreach through some events that we do for outreach workers, for consultants, and other things. Next slide, please. And you will see here that actually about half of the reach was thanks to Meta ads, and another quarter thanks to Google Ads. So indeed, these are the tools that we are now capitalizing on, and most of our investment now in the last several months is really on Meta ads and Google Ads. Next slide. And you see this is the most cost efficient one. So every conversation that we get on our social work with Meta ads costed us less than $50, and with Google Ads less than $1. So yes, it does make a lot of sense to invest more into these means. Next slide, please. And so in future we are expanding now for several more countries: Moldova, Georgia, Kazakhstan, and it's easily scalable, especially if you use the existing database. You just record your character and also check the database with any specific information and referral data you would want to use. Next slide, please. We would be happy to share this experience further. In this presentation, there are some more solutions that we have used based on artificial intelligence and some of the digital techniques available now. You are welcome to look through themselves yourself, and I would be always happy to respond to some of the questions. So thank you very much for this exchange opportunity.
Thank you. Thank you so much, Tatiana, and apologies again. I think time is never enough. We want to move on to the next presentation by Yen Hecht and Tigan Masugu from the Building Healthy Online Communities. Yen is the founder and the director of BHOC, while Tigan is the Global Engagement and Outreach Director. Welcome so much.
Thank you. And can I just make sure we have our slides? It's a black slide that says BHOC plus Grindr. There we go. Excellent. Thank you so much. Good morning, good afternoon, good evening. Thank you for inviting Tegan and I to join you. We're grateful for the opportunity to share about our partnership with Grindr and how it fits into our HIV self-testing model. Next slide, please. So you've probably heard about Grindr, and you know who Grindr is or what Grindr does, but not of BHOC. So Building Healthy Online Communities, or BHOC for short, is a small nonprofit that's based in the US. And up until recently, we've only had 2 staff. We currently have 9. And we've been around since 2014, specifically working with dating apps for the purpose of connecting key populations to health information and resources. And we do this in 3 main ways. So we work with apps to recommend and integrate features into their product that enable communication about sexual health. So for example, if some of you have been on apps, you might have noticed that you can indicate being on PrEP in a profile field, as an example. We've worked with them to put those profile fields there. We also work with apps to communicate with users during health outbreaks and through other in-app messages, and also to include sexual health information on the app. And have written many FAQs or sexual health resource information pages and articles. But what I'm going to talk about today is around self-testing. So back in 2017, we worked with one of our academic partners, Emory University in the US, and we were able to see from a very large sample of MSM in the US that there were, amongst the many, many people who are using dating apps, about 85% of MSM in the US reported using a dating app within the past year to meet a partner, that many, many of those folks had not tested for HIV within the past year or ever. And so that led us to want to develop an HIV self-testing platform. In 2020, we launched a platform called Take Me Home that was based in the US. And we were working with various health departments across the US to help pay for those self-test kits. As we were seeing success with that, CDC recognized that model and put out some funds to support a national scale-up or a national distribution program. Our program was selected and has been scaled up. So that is a program that is now led by Emory that we are a part of. And in doing that, we recognized an opportunity to take the partnership that we'd been working on with the apps in which we'd been promoting self-testing and actually create an in-app button on Grindr and as well as some other apps. So for these last couple of years, we've been working with Grindr and other dating apps to allow this technology that has already been built into the app into areas with in other countries. Next slide, please. So our model is an example of a way to leverage public-private partnerships. In every country that we work with, there's an in-country partner that's leading the work, and we're supporting their existing infrastructure to increase demand generation for self-testing through dating apps like Grindr. So we don't create contracts or charge for our work, but rather offer technical support to these in-country partners. All the partners we work with also receive free messages from the Grindr platform. And the countries that we work with need to already have the funds to cover the costs of the test kits and the delivery of the kits, but then we're able to support the process for development of an online platform to receive the test kit orders. So this visual is a representation of the partner countries that we're currently working with. In planning, which is in purple, this group is finalizing the logistics for their HIV self-test kit pilots. They already have stakeholder buy-in in those areas. In the ready to launch, which is in blue, this group has already received the stakeholder buy-in, but they also have procured the kits and they have the funds to support the distribution of the kits. And then in piloting, which is in yellow, at this point, the users, meaning the Grindr users or dating app users, are starting to see inbox messages so that they can order a kit. So they're already distributing kits to people on the apps. And then finally, in the pink, which is fully integrated, these are the pilots that have been scaled up to a regional or national level. And they're now using that in-app button that I described so that ongoing availability of the self-test kits is always there in the app. Next slide, please. In the past 2 years, we've been able to work with Grindr and other apps to direct their users to our ordering platform. Now, the partnership with Grindr is the largest by far, and that has led directly to over 400,000 test kits being delivered. Most of these test kits have been part of the nearly 1 million that have been distributed through the US national program. And I want to point out that even at this volume, 25% of our tests are going to first-time testers. So we're really reaching a population that is otherwise not receiving services and not being tested. And we're also seeing pretty high positivity rates relative to in-person testing in most locations. And as you can see from the prior slide, we're also now bringing this model to other countries, and those other countries are now in plans to scale up from their pilots. Next slide, please. So adapting to the local environment is always key. And the model I'm going to describe here is the original model that is used as a starting point for most of the partnerships. So the process begins with a user being on the app. Again, this is a way to reach people where they are. They're on dating apps. And that user either sees a message or is on the app and sees a link or button that is already there that says free HIV test. From clicking that button, they are then directed to the in-country partner ordering website. And one thing that's really important to note is that all of the data is maintained by the in-country partner, not by Grindr. So the user enters basic information to determine eligibility, such as their zip code or age, and then they share their address for where they want to receive the test kit. This is also an opportunity to gather limited demographic and risk behavior data, but we really, really try to keep that short because we want to keep it as simple as possible and really seamless so that folks can order a test kit very quickly. The local testing partner will then provide a confirmation either through email or SMS that they've received their order, and then the local testing partner then fulfills and delivers the kit. And I'll note that this varies quite widely across locations as to how that delivery occurs. Depending on the site, this could include at-home testing, or it could include self-collection of a specimen that's then returned to a lab. And results are seen only by the end user, so they're not shared through the platform. And in-country partners are vetted at the beginning of this process to ensure that they're suitable to provide provide follow-up care or refer to follow-up care and connect to other services such as PrEP, condoms, etc. Next slide, please. So just to show you what one example of an in-app message, this is called an inbox, and these are typically designed by in-country partners, but BHOC can provide support in doing so and also share successful examples of sample messages. And it's also possible to have text messages with no design that is also available. And now I'm going to hand it over to Tegan to take it from here.
Thank you so much, Jen. Next slide. Great. So when it comes to our work, we focus heavily on reaching at-risk men equitably where they are and at their point of need. And through Grindr being the networking application for LGBTQ+ men, it gives us a chance to do so as well too. Now, our work with Grindr is at a no cost. So that means what we offer to country partners is free of charge, no cost. But we're able to provide technical assistance to those country partners that we work with. That allows them to not only save their resources, but to also use those resources for like staffing and self-testing kits. Now, the ability of Grindr being an application allows us to leverage geospatial mapping, which allows us to target specific areas. So in a city, you can target a region and even a specific like area of that city as well too, or even in multiple cities as well too. Now, we provide technical assistance to country partners by optimizing how we do logistics and planning with them, supporting user surveys, and offering real-time insights on how the whole entire pilot is going, how they can get more feedback from the users, but also what it can do to maximize the whole process. And we focus heavily on working with the country partner because they are leading the charge on the ground. So we want to hear from them. We want them to lead and adapt their model to really reach this at-risk command so that they can eliminate barriers, reduce risk, and maintain discretion. And for the work that we do, we know that this work is an entryway for STI testing. Research has shown that several gay and bi men and even trans men, this is their first time, when it comes to STI testing as well. So we see this as an entry point to not only do STI testing, but to link to PrEP. And for those that do have a reactive test, place them on the continuum of care. Next slide. Overall, this is also part of our global vision as well, too. We want to normalize HIV self-testing. We realize that it's very key and important in this day and age for us to normalize testing for at-risk men. We also want to really advance inclusive HIV prevention for marginalized and high-risk groups. For a lot of these, men, there are so many barriers, be it stigma, be it financial barriers, be it also distance as well too. So this work allows us to advance inclusive HIV prevention for these marginalized men. We know that this work is also a way for country partners to promote early detection because the earlier you know, the better you can, take more informed decisions linked to care, reduce stigma, and save lives. Lastly, we also want to work with our country partners to build a national case as to why this work is important. And also that way allows them to get not only national investment and global investment, but to accelerate progress towards the 95-95-95 goals, whereby 95% of people living with HIV can get the status. They can also get diagnosed and can also be put on ART as well. Next slide. This work is very country-led, and we focus heavily on ensuring that we can work with our in-country partners in so many ways. Now, for any in-country partner that we choose, we're very thoughtful with how we choose them. So here are some factors that we look into. One, we look into the country need. Every country has a different level of need. So where there's more need, we prioritize. But also every country has HIV self-testing on its agenda as well too. So we want to know where is HIV self-testing on your agenda and what resources within the country needs to be moved to make HIV self-testing a reality. We know different countries have different policies and requirements. So we also want to understand that and see how best we can work with a country partner to really get them ready to meet those requirements, but to also present the evidence that they may need to either regional governments or national governments. Any country partner that we work with has to have a connection to sexual minority communities. The reason being for this is we want there to be trust in the system that exists, but also trust in the country partner as well too. We know that this work is very technologically driven, so we want to ensure that the country partner has infrastructure for ordering, but also the infrastructure for being able to deliver the kits and support as well to users. We want users to feel comfortable and supported the moment they request a kit, to the moment the kit gets to their home, to the moment that they're even done with the self-testing kits as well too. Lastly, funding for the distribution of this kit is important. We don't provide funding to our country partners. We leverage the country partners' resources so we can support them with evidence generation, support them by showing them how they can tap into different potential financial pathways, but we're not giving them money for this pilot. Next slide. Here's a case study of our work in Mexico and Cambodia. In the Mexico context, it's very unique and it's very key. We've worked with a group called CICIDAT to secure funding for groundbreaking pilots, whereby CICIDAT is not only connected to different stakeholders, but they've been able to showcase sort of like the need for this in Mexico. In the Mexican context as well too, we focus heavily on evidence generation. So currently now we have been a pilot that soon will be piloted in Mexico across different cities, about 4 cities, whereby at-risk men can get self-testing kits in the comfort of their home. And with the Mexican example, we know that, when we empower men to have, these kids, it's not only a way for them to take charge of their health, but a way to also encourage others as well too. And then the process for Mexico was, one, ensuring that the kids can be ready. So doing everything that we can do to support that in the whole process of getting these kids ready, getting the evidence, aligning stakeholder goals with objectives, but also ensuring that the pilots can have impact and it's feasible not only when it comes to ethics in the country, but feasible when it comes to really the different cities at hand. Next slide, please. In the Cambodia context, Cambodia is using a delivery company known as Food Panda or Panda Send. And in the Cambodian context, we've been working with them since last year heavily on just ensuring that this pilot can happen. So in Cambodia context, you have a scan of local delivery services. They had to make sure that the delivery service was the right one. So we relied on them heavily for that insight and that intel. Building out the ordering platform was key, and ensuring that when users get the kits, it's confidential, it's discreet, and also stigma-free. We want users to feel comfortable when they get the kits, but also ensuring that there are different distribution points in the country. So if somebody's in a different part of the city, in Phnom Penh, they can get that distribution, that kits as well too. And then also ensuring that users have all the resources as well during the testing process and even after when it comes to testing support. In the Cambodian context as well too, we've seen a very much collaborative approach with the HIV/AIDS Alliance in Cambodia. Men's Health Cambodia as well too has been helpful as well too. But seeing the government involvement, whereby the government is so much invested in ensuring that this can be a success. So seeing how they're also able to really strengthen the whole entire process and give insights as well to in Cambodia. Next slide. Working with us really is a unique way to get HIV self-testing kits to at-risk men where they are and at their point of need. We know that through our work, we're able to not only reach these men, but also through our work, we are able to really impact lives that can not only strengthen the community health, but also national health, which in turn helps global health goals and outcomes when it comes to HIV. So we really focus heavily on identifying countries that already have a mechanism in place for BHOC and Grindr to work with the country partner. We want to support the work post-pilot integration. As Jen mentioned, we're not only interested in a pilot, but seeing how that pilot can also scale up in the long run. We also want to be able to pinpoint strategic funding pipelines for countries. That way countries can really feel supported to not only get the funds, but to make the case for larger investments overall. And also mobilization of the kits is really key. Without the kits, this work cannot be done. So getting those kits to these at-risk men where they are is important, but also being able to mobilize different funding pools, but also different national and global stakeholders. And then the in-app messages. This whole entire innovation is driven by the in-app messages. And we know that the end user can see the messages where the end user is at. So how can we get the messages to the end user where they can not only feel propelled to order a kit, but also feel motivated to really have that conversation with their sexual partner and even their friends on the importance of this work. Next slide, please. And there's Jen's contact, my contact. Thank you.
Thank you. Thank you so much, Ian. Thank you so much, Tegan, for that very insightful presentation. Now we have the session on the question and answers. And I know that we have the Q&A section. A lot of the questions have been answered by our presenters. I'll handpick just a few for those that may not have gotten to the Q&A section. There are a lot of questions around how people can access the presentations, and there is a link. There's a link on the chat. You will be able to access the recording and the slides on the hivinterchange.com. So once after this webinar, once you click on the link, you will be able to access the presentations there. But just some of the questions, just to pick up a few of the questions that were shared or that were posted for Hamza Trust. We had a question on how you could have expanded the 0.8 million website traffic, and how many of those users take further action, like engaging with more content tools, virtual navigators, and how Hamza is able to check whether these are real people and not such tools. And Achana responded and said that engagement is about 30%, and they have mechanics on the website to rule out bots, and the mobile number raises an OTP code, which is unique. So thank you so much for responding to that, Achana. We had Nicholas who wanted to, who was appreciating the wonderful work by Hamza and wanted Achana to speak to how they create and generate the content, with who and how do you test. And Achana said that the content is generated in-house by a team that consists of a designer, ad managers, and they have access to community consultations, as well as collaborating with networks who help to create effective campaigns. Moving further on, I think a lot of the questions were for Hamza Trusts. I'm just trying to see, yes, there was a question here for Alliance. And the question was, are you thinking of the population offline? Is there any opportunity for dual approach? And Tatiana responded and said that they are transferring the database into an offline modality in an app, and it will be more limited without a ChatGPT option, but available offline. Thank you so much for sharing that, Tatiana. We had a question also for BHOC, how many people get the self-tests, who get the self-tests actually do the tests, and do you follow up that the test was done? And Yen has responded and said they do ask this question from their work and many research projects. They see about 90% of the people who order the tests do take them. In many cases, they are able to send 2 kits and encourage people to share with them. Reaching additional people within the key populations. So those are just a sample of some of the questions that were asked. If you still have a question, you can. We have a few minutes, and you can post it on the chat. But just in summary, to say that I wanted to really appreciate the Global Fund, especially for the investments in communications, information, and demand generation. This is a really critical area if we are to win if we are to achieve the targets for HIV prevention, because much as you have services and you have products, these products cannot move on their own. We really do need demand generation. And I want to appreciate also our presenters who went at great lengths to identify innovations, digital innovations that are working. We are moving away from traditional media, and there's a growing consumption of digital platforms, and we've been able to see how those are working. They offer more flexibility for consumer-centered interaction, as well as flexibility in reaching especially hard-to-reach populations. We've been able to get a demonstration of how partnership with the private sector works, using Grindr, for example, as a digital platform for scaling access to HIV self-testing. We have country-level demand generation. We have seen country-level demand generation in India for hard-to-reach populations and how they are using that to close the gap. I also liked the use of the innovative digital human assistant to share information on prevention, the virtual social worker, so to speak, in Ukraine, Eastern Europe, and Central Asia. So I maybe I just want to ask if there's someone who has a question live, and maybe our team can unmute. If you have a question that you feel you haven't had answered. Yeah, so we have Victoria who's saying that we have self-test kits in the country, but the peer educators are not trained to counsel and to distribute the kits among the key population. Maybe this is to ask how can they, to BHOC, what would you advise?
Yeah, I think that's a great question. And one of the things that I want to indicate is that in our work, we have sort of customer service and support for folks who do have questions. And when we're operating at scale, we recognize that it's not realistic for us to offer counseling to every person. So we have it available. We send out the kit. We send out with the kit. There's a lot of information, not just the instructions for the kit, but also additional information and links back to the website for additional resources. Our contact information, both through email, SMS, phone, is available. What we find is that less than 1% of the people who are using the kits reach out. And many of those folks who are reaching out either because they had a logistical question about, shipping, or sometimes that they want additional resources. So what we're finding is that while having the ability and offering the service of counseling is very important, most folks do not need it. And I think that's really important, especially when you're thinking about scale, because to reach every single person and provide counseling for every single person may not always be realistic at that scale. But as long as you're available for those who do need it, that's how the model has been working.
Thank you. Thank you so much, Ian. I also wanted to highlight that Alliance for Public Health had a case on how they've used AI to improve testing yield. So once you do get to the presentations, look out for that. We're not able to present it because of the constraints on time, but they do have demonstrable case where they have used AI to increase HIV testing yield. And I'm sure that would be of interest to everyone, because as we continue to test, yield becomes a challenge. But if we can use AI to increase yield, that will be great. We have Jane. She's saying that they have developed an app for demand creation and last mile distribution, but have not officially launched due to financial constraints. And I think that's a case where you can explore public-private partnerships in order to ensure that you're able to reach the populations that you're targeting. So at this juncture, because we don't have any more questions, I want to take this opportunity to really appreciate the Global Fund for partnering with us on this, and our wonderful presenters for showcasing your work, and all our participants for joining us on this webinar. The presentations, the recordings will be available, as I've said, on the HIV interchange. Please do feel free to reach out to any of our presenters if you do have follow-up questions. Otherwise, for now, thank you so much all for joining us, and hope to see you next time. Thank you.